Vanakkam. We have learnt all about the classification of hypoplastic thumb in the previous video. The principles of management of the hypoplastic thumb are also based on the classification that we have already seen. Sometimes it may be a single procedure, sometimes it may be multiple procedures in stages. Understanding what is required and understanding when to get it done are the basics of understanding the management of hypoplastic thumb. And this time we have a special guest in this video to tell us more about his experiences with the management of hypoplastic thumb. This video will be about the principles of management of thumb hypoplasia. When considering thumb hypoplasia management, we need to remember that in spite of adaptation to the functional deficiency, the child continues to have unique problems with pinch like precision, pulp, key pinch, and also grasp, the precision, span and power grasp. So obviously the hypoplastic thumb must be reconstructed to give it a good function. And to give it a good function, we need to understand what are the ideal prerequisites for a functional thumb. An ideal thumb consists of all the bony structures and soft tissues of the thumb with a mobile stable carpometacarpal joint, a good first web space with adequate width and depth, mobility in at least two of its three joints, metacarpophalangeal joint stability, adequate motors for strong metacarpophalangeal or interphalangeal flexion and extension, and also the capacity to be placed in a palmar abduction for opposition. When we consider type 1 or mild hypoplasia of the thumb, which is seen mostly in patients who have severe radial dysplasia in the opposite upper limb, they are not usually functionally impaired much because they have very little or no difficulty with key pinch, pulp to pulp pinch, opposition and grasping activities. So surgical correction is not often needed. If at all surgical treatment is needed for type 1 hypoplasia of the thumb, it may be required to release a tight thumb web. Here the release involves not only the skin, it also involves release of the tight facial bands, anomalous tendon and muscle anatomy, and also stiff joints, and we shall see more about it later on in this video. In type 2 or moderate hypoplasia of the thumb, there are three specific problems that must be addressed individually, and one additional problem in severe cases of type 2 hypoplasia. These are more often seen in type 3A thumbs, where all these problems exist. We have discussed in detail about these problems in the previous video, and you can click on the icon above to see the details. These four problems are narrowed first web space, instability of the metacarpophalangeal joint, poor palmar abduction, that is opposition, and rarely seen in severe cases is abduction posturing of the thumb or pollex abductus, where there are problems in the interphalangeal joint flexion and extension. The narrowed first web space must be treated with release of the first web space. The instability of the metacarpophalangeal joint must be corrected with stabilization, and the poor palmar abduction must be corrected with tendon transfer. We need to note here that these surgical procedures, release of the first web space, stabilization of the metacarpophalangeal joint, and tendon transfer for palmar abduction, can be done in a single stage. In severe type 2 and type 3A, we will also have to restore the interphalangeal joint movement of the thumb. But restoration of the interphalangeal joint motion of the thumb has to be done in two stages. We have seen the names of four surgical procedures that need to be done for type 2 or moderate hypoplasia of the thumb. Let us see the details of these procedures. The first surgical procedure is the release of the first web space. Widening of this first web space is very important, and release and surfacing with the skin flap is even more so. The options available for resurfacing are local transposition flaps or rotation flaps, regional island flaps, distant pedicle flaps, or even skin expansion. But the sheet anchor of resurfacing of the first web space would be by the use of local transposition flaps in the form of 4-flap Z-plasty. 4-flap Z-plasty increases the length of the web space by about 150% theoretically and provides a rounded contour. The marking for the 4-flap Z-plasty is as follows. First, the line representing the thumb web is drawn. Then from one end at 90 degrees, an equal length line is drawn both on the dorsum and on the palmar aspect. These two angles on the dorsum and the palmar aspect are now bisected with a similar length line. This constitutes the 4-flap Z-plasty. The incisions show the pattern of skin flaps, but the release of the skin alone is not enough. We also need to release the tight facial bands, the stiff carpometacarpal joint, and release of any anomalous muscle that is causing a contracture of the thumb web like the lumbricalis pollicis muscle. The second surgical procedure required is stabilization of the metacarpophalangeal joint. The options available are tightening of the existing ligament of the joint, free tendon graft reconstruction, arthrodesis or chondrodesis, or ligament reconstruction using the end of a tendon used to improve palmar abduction like opposition. Tightening of the existing ligament can be done by plication or incision of the ligament and closure in the form of a pants over vest repair. A free tendon graft reconstruction can also be done to reinforce the joint capsules, and palmaris longus, extensor digiti minimi graft can be used, and attachment should be by periosteal tunnels or drill holes if the patient is older. Both the radial and ulnar side ligaments may have to be reconstructed. Arthrodesis or chondrodesis are usually indicated in type 3A thumbs, where there are flail joints and poor extrinsic motors. Chondrodesis obviously is preferred in the young child and arthrodesis in adolescents. When a tendon transfer is done to restore opposition, the end of this tendon can be used to reinforce the joint capsule of the metacarpophalangeal joint by taking one slip through the metacarpal on the ulnar side and the other slip for the radial side. This is shown in this picture where an opponent's plasty is done using the flexor digitorum superficialis of the ring finger. The end of this tendon is used to reinforce the metacarpophalangeal joint capsule. The third important surgical procedure is the tendon transfer for palmar abduction. The options available are transfer of abductor digiti minimi, which is the Huber's transfer, transfer of flexor digitorum superficialis of the middle or ring fingers, or even the transfer of extensor carpi ulnaris or extensor indicis proprius. For performing the transfer of the abductor digiti minimi, incision is made from the pisiform proximally to the mid-axial line of the proximal phalanx of the little finger distally. A skin island can be taken along with this transfer to augment the bulk of the thenar eminence. The muscle is detached from its distal extensor and bone insertions and can be raised along with the flexor digiti minimi if the two muscles are very closely attached together. We need to identify the proximal axial pedicle to the muscle in order to make sure that we do not injure it. The muscle can be islanded by detaching from the pisiform also. The muscle is then passed through a subcutaneous tunnel to the thumb metacarpophalangeal joint in the plane between the skin and the palmar fascia. It is now attached to the metacarpal, the collateral ligaments at the metacarpophalangeal joint, or the abductor aponeurosis. An alternative procedure is using the flexor digitorum superficialis of the middle or ring fingers. This can be done through a longitudinal incision at the base of the respective finger. It is cut as far distally as possible. It is delivered through an incision over the flexor carpi ulnaris and then passed through a subcutaneous tunnel to the radial side of the thumb. The pivot point is either through the Guyon's canal or around the flexor carpi ulnaris, and the insertion is the same as for insertion of the abductor digiti minimi transfer that we have already discussed. The thumb is placed in 45 degrees of palmar abduction and immobilized for 3 weeks. The fourth surgical procedure that may be required in some patients is restoration of the interphalangeal joint motion of the thumb. This problem will commonly be encountered in severe type 2 and type 3A thumbs. We need to correct the pollex abductors also. It is done as a staged procedure in which the first stage consists of release of the interphalangeal joint and tendon transfers done in the second stage. Release of the interphalangeal joint in the first stage is by using the same incision as for thumb web release. Here, through the radial end of the incision, both the FPL, that is the flexor pollicis longus, and extensor pollicis longus should be released. After dissecting these tendons, we need to give traction on them and look distally for any interphalangeal joint stiffness and proximally for the gliding movement of the tendon, that is the muscle belly status. We must then divide the interconnecting bands between the FPL and the EPL along the radial border of the metacarpophalangeal joint and the proximal phalanx. This is usually what is referred to as the pollex abductus, which is released. If there is a good flexor pollicis longus and extensor pollicis longus, we need to do a dorsal capsulotomy of the interphalangeal joint to make it much freer, and also centralization of the tendons with pulley reconstruction. If the FPL and EPL are poor, we need to proceed with tendon transfers in the second stage. The tendon transfer could be the flexor digitorum superficialis of the ring finger to get back interphalangeal joint flexion, or the use of extensor indicis proprius to get back extension of the interphalangeal joint of the thumb. Now we come to the management of type 3 or severe hypoplasia. This could be type 3A or type 3B and type 3C, as we have already seen. The management of type 3A is very similar to the management of type 2 because it has the same problems as type 2 hypoplasia of thumb, but in addition, the management of the flexor mechanism is important in type 3A, which we have already described as a staged procedure. Type 3B and type 3C can be considered together for management purposes because the reconstructive requirements are almost similar. There are two major options available for the reconstruction of such thumbs: pollicisation and other procedures. To understand these procedures, we shall first see what are the requirements for reconstruction. First, we need a thumb length with all the bones and joints. Then, we need to have a first web release done, metacarpophalangeal joint stabilization done, opponent's plasty, and then staged extrinsic tendon transfers. It would be interesting to note that all these requirements can be met with one surgical procedure called pollicisation, whereas the other procedures described are all to attain a good thumb length with the bones and joints. The rest of the requirements will have to be met by surgery in stages. So how is the decision made about the protocol of management? First, the surgeon has a role to play, and a bigger part in decision making is by the parents of the child. Careful observation of the child at play will usually direct the surgeon and family towards the best course of management. For instance, a child who bypasses the hypoplastic thumb before reconstruction will usually continue to do so following reconstruction also. The size of these thumbs at birth make reconstruction appear attractive to many parents who are often reluctant and some strongly insistent about considering any other option. Most undecided parents usually make up their minds after observing other patients with their newly pollicized thumbs. Some parents are insistent about having 5 fingers in the hand, and this is common in our country and other Asian countries. First, let us see the basics of the pollicisation procedure. In this procedure, the index finger is transferred to the position of thumb after removing a portion of the index finger metacarpal. The metacarpophalangeal joint of the transferred finger will act as the carpometacarpal joint of the thumb. The tendons and muscles acting on the index finger will now act on the thumb to provide opposition. The advantages of pollicisation for type 3B and type 3C are so much that it is a gold standard for treatment of such conditions. It involves the natural use of the index finger for pinch. The other advantages are that it is a single staged procedure with a shorter operative time when compared to the other procedures. It restores good functional range of movement of the thumb. It retains growth potential and indicated also for types 4 and 5 hypoplasia of thumb. It does have some disadvantages also because we need to remove the small thumb that is already present. This surgery will result in a 4-finger hand because the index finger is being used as the thumb. It is cosmetically less optimal, and according to a study it attains only 21% of grip strength, 22 to 26% of tip pinch, and has a total mobility that is about 50% of a normal thumb. We need to remember that the functional and aesthetic result depend on the preoperative condition of the index finger and the age at which surgery is done for the child. As an alternative to pollicisation, many procedures are described. These procedures can be considered when parents do not want the removal of the existing thumb, or when parents want the child to have 5 fingers in the hand, and also the parents are willing for donor site morbidity on the foot and also for multiple surgery stages. If this diagram represents the type 3B or type 3C hypoplasia of thumb, the non-vascularized phalanx is inserted to replace this hypoplastic metacarpal bone. In all these alternative procedures, intercalated bone grafts or bones and joint or the entire toe can be used for reconstruction of the thumb. If bone grafts or joints are used, they may be vascularized or non-vascularized, but multiple stages will be required and tendon transfers will also be needed to get back function. The disadvantages of these procedures obviously are the lack of carpometacarpal joint mobility, the lack of growth, poor motion, and the requirement for multiple stages. Even with all these disadvantages, the biggest advantage would be that the child will still have 5 fingers in the hand with some amount of mobility and a useful thumb. Let us see what are the other procedures that can be done to reconstruct the hypoplastic thumb in type 3B and type 3C. Non-vascularized 4th metatarsal bone was used by Chow et al. Vascularized 2nd metatarsal bone was used by Schneider, and non-vascularized metatarsophalangeal joint transfer was described by Fouché et al. Vascularized second toe transplantation for reconstruction of the thumb was popularized by O'Brien in 1978, and vascularized 4th toe to hand transplantation popularized by Ozols in 2019. But these thumbs were very short. Tu et al. Described vascularized second toe along with the metatarsal bone transfer, and he used tendon rebalancing methods to stabilize the metacarpophalangeal joint. Ozols in 2020 made the vascularized second toe to hand transfer more stable by arthrodesing the metatarsophalangeal joint. In the meantime, non-vascularized toe phalanx transfers were described by Kawabata in 2018 and non-vascularized third and fourth toe phalanx transfers by Balakrishnan et al. In 2020. According to Balakrishnan et al., the selection criteria for the third and fourth phalangeal transfers were children presenting with hypoplasia type 3B and type 3C only, having isolated thumb hypoplasia with no associated radial longitudinal deficiency, with the distal segment of the thumb being intact and the hypoplastic thumb being placed proximally on the radial side of the palm. The digits on the donor toe should also be normal. The steps of the procedure are as follows. A dorsal midline longitudinal incision over the proximal phalangeal region of the toe that is selected is made, extensor tendons retracted, extraperiosteal harvest of the toe phalanx is done, and the extensor tendon is then sutured to the flexor tendon in the toe to prevent much shorting of the toe. The harvested phalanx is placed in a pocket created in the thumb and fixed with a straight K-wire, and before that, if multiple phalanges are used, the cartilaginous portions are removed to help in bone-to-bone union. The abductor pollicis longus tendon is reattached to the base of the transferred phalanx graft. The K-wire is retained for 8 weeks, periodical assessment done at 3-month intervals, and the second stage of surgery will usually consist of a Huber's opponentsplasty. Let us hear what Dr. Balakrishnan himself has to say about this procedure.
In type 3 thumb hypoplasia, you have got three varieties. In type B, there will be loss of or absence of proximal third or half of the thumb metacarpal. The option available were pollicisation, or nowadays we do toe phalangeal transfer to replace the lost metacarpal bone. This may not give a circumflexion movement like the pollicisation, but parents prefer this method because the child will have five-fingered hand. This is very essential for the Asian population. They don't want to lose the fifth finger. So we always prefer to do the toe phalanx, which is always taken from the third or fourth toe, depending upon the length and size of the toe. When we harvest the toe harvest must be done extraperiosteally, and it should be the head or the base should not be damaged, so that the growth will be better. Your experience for 15 years, this phalangeal transfer had no resorption of the bone. Even we have done double toe transfer, taking two toe phalanges from the third and fourth toes for a type C hypoplasia where the entire metacarpal is absent. And those two toes are given. It's very essential that you should fix the vestigial APL tendon to the base of the distal toe, or even when you do a single toe, that vestigial tendon should be fixed to the base of the transferred toe. So to keep the alignment and also to keep the strength of the toe. Subsequently, we do second stage at the end of 6 months for apposition. So toe phalangeal transfer is a two-stage procedure. Still, our Asian parents never hesitate to undergo for two transfers. And this is a very good procedure for the type 3 B and C, not for A, B and C, but it is a two-stage procedure. When we do the phalangeal transfer, as I said earlier, you retain the five fingers. The finger which is transferred also behaves like the pollicized finger. Parents are happy, children also happy, but it needs some physiotherapy to get this reconstructed thumb to move, oppose, and do any movement. But these children may not have the IP joint movement, whereas in pollicisation they also have IP movement. To do this, we have suggested tendon transfer for the IP joint movement. But most of the parents, they didn't like it. They like to have only a five-fingered hand, which is mobile and able to oppose, able to pick up objects. Patients are happy, parents are happy.
So far, we have seen the different procedures that can be done for reconstruction of type 3B and type 3C hypoplastic thumb, and also the role of pollicization. How do they compare with each other? In a study by Tan et al. In 2013, where pollicization was compared with microsurgical reconstruction, it was seen that early motor and sensory recovery was achieved in children who underwent pollicization. The functional result and range of movement was better after pollicization than the children who underwent microsurgical reconstruction, but the parents of children who underwent microsurgical reconstruction had a higher rate of satisfaction. Similarly, in a study conducted by Anil Bhatt et al., comparing the results of toe phalanx transfer and pollicisation with an average follow-up of 7 years for the toe phalanx transfer group and 6 years for the pollicisation group, the Kappanji score was 6 in 3 children, 5 in 2 children, whereas in the pollicisation group it was 9 in all the children. The movements of palmar abduction were 24 degrees in the toe phalanx transfer group and 40 degrees in the pollicisation group, and radial abduction was 36 degrees in the toe phalanx transfer group and 45 degrees in the pollicisation group. The mean visual analog score with regard to function was 6.8 in the toe phalanx transfer group but 9.2 in the pollicisation group, and the VAS score for appearance was 6.4 in the toe phalanx transfer group and 8.8 in the pollicisation group. It was also noted that there was no resorption at a mean of 7 years in the toe phalanx transfer group. For the type 4 hypoplasia thumb, otherwise known as the floating thumb, index finger pollicisation is the treatment of choice, unless there are too many cultural or parental concerns. There have been reports of reconstruction for a type 4 hypoplasia using microvascular transfer of a polydactylous big toe. This was an opportunistic reconstruction but cannot be described as a protocol. For type 5 hypoplastic thumb, where there is total absence or aplasia, index finger pollicisation is the treatment of choice. Osteoplastic reconstructions and microvascular transfers are not considered. Now let us consolidate all that we have learned about the principles of management of hypoplastic thumb by summarizing it. For type 1 hypoplasia, which is minor generalized hypoplasia, no surgical treatment is usually required. For type 2 hypoplasia of thumb with absence of intrinsic muscles, first web space narrowing, ulnar collateral ligament insufficiency, and sometimes pollex abductus, opponentsplasty, first web space release, and ulnar collateral ligament reconstruction need to be done. For type 3A, the findings are similar to type 2 along with the extrinsic muscle and tendon abnormalities. So opponentsplasty, first web space release, ulnar collateral ligament reconstruction of the metacarpophalangeal joint and interphalangeal joint movement restoration need to be done. For type 3B and 3C, there is a varying involvement of hypoplasia of the thumb metacarpal and no stable carpometacarpal joint. Pollicisation of the index finger can be done, or alternatively, if the parents prefer 5 fingers in the hand, vascularized or non-vascularized toe phalanx transfer or vascularized toe transfer along with reconstruction can be considered. For type 4 floating thumb or type 5 aplasia of thumb, pollicisation is the treatment of choice. So we can make out that pollicisation is one of the most important surgical procedures required for the reconstruction of severe hypoplastic thumb, and we shall see more about this pollicisation procedure in our detailed next video.
I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about hypoplastic thumb classification and the other congenital anomalies. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics.